So today is all about power and self-determination and listening to people who have walked this walk, so that you as advocates can hear and deepen our understanding about what people need and benefit from, and also to never ever forget the power of self-advocacy. That's kind of what today is about. And I know you guys do get this, but we can't hear that too much. So a couple of things about the session. I'm going to read out Lucy's bio, because this woman is just incredible. Lucy is a disabled person who lives with a life-limiting condition and a multitude of medical needs. She's vast experiences of health and social care services as a result of this. Already 10 years beyond her original prognosis, Lucy devotes her life to making a difference for all, but especially those with disabilities, impairments, and life-shortening conditions. She was named as the 9th most influential disabled person in Britain in 2019. And I think, did you make it on the list last week as well?
Yep.
Wowzers, incredible. Lucy works with and for a number of organisations, local, national and international, and she affects change at the highest levels. She also runs her own business, but it's not one business, is it, Lucy?
No, it's a multitude.
It's a multitude, so it's businesses. And then lastly, many people also cannot fail to think of Lucy without thinking of her gorgeous assistant dog, Molly. And Lucy's hoping Molly won't try and join in her speech, but we just never know, do we?
No. Yes.
Excellent.
It's
so
Lucy,
I'm gonna just give you, sorry, I should have done this before. So you can share your screen now.
Brilliant.
If you want to pop your presentation up, and then I'll turn my camera off and leave people in your most capable hands. Right, I'll be here with the chat if you need anything. Okay.
Brilliant. Thanks, Kate. So hello, everyone. Obviously, I'm Lucy, as you've just heard, and I wanted to speak a bit today about my experience of personalised care, especially personal health budgets, advocacy, and also my lived experience and how important lived experience is to what we do, because it affects all of us. We all have lived experience, and it all changes our opinions, our behaviours, our attitudes, but also how we act and see the world. So I wanted to give kind of insight to that. But first off, so who am I? Well, I'm a public speaker. I do a lot of public speaking. We go to festivals every year with Festival Spirit to WOMAD or Wilderness, and unfortunately this year and probably next year it's not going to happen, but we've been able to have amazing experiences because they have specialist accommodation at festivals for us. I'm a daughter, a sister, a friend. I'm also mum to Molly Dog, who is rather infamous. So Molly Dog with a blog, or Molly Dog as she is on Twitter, she is a big part of my life and a big part of my confidence, and has enabled me to do so many things. But sometimes I think people invite me to things just to see her, to be honest. But I'm a person with lived experience. And what does that mean? So to the obvious, I live with a life-shortening illness. I have a syndrome without a name, or a SWAN. I have complex medical needs and I have a physical disability. But that's not really who I am. That's part of Lucy, part of the person, but not actually the full person. I'm also a business owner, a support broker, an advocate, a consultant, again, public speaker, patient or peer leader, charity trustee and co-researcher. But I try and get people to think about me as a whole individual, you know, what I like doing, who I am, where I go, the people I spend my time with. I'm a multidimensional person, as we all are. But so often in the eyes of the system, I'm seen as a patient or a service user. And actually, I'm not. I'm a person first. Yes, I'm a patient in the NHS. Yes, I used to use social care services, but I'm a person first. And I have a lot of different parts of me that perhaps the system doesn't always see. And it's about valuing people for the assets they bring, the skills, the confidence, the knowledge, but seeing everybody as an individual, as a unique person, and taking into account their wishes, their needs, their preferences, and what matters to them, not just what matters to the system, but what matters to that individual. Personalised care. So it's an approach to care. It's not a new buzzword. It's not a new way of doing things in its entirety. It's just an approach to care, thinking about the individual as an individual with a multifaceted self, you know, lots of different parts to them, lots of different parts of their identity, their abilities, their wishes and needs and preferences, their hobbies, enjoyment, all those kind of things. And personalised care now is integral to moving our health and social care forwards. Obviously in social care, personalisation has been on the agenda for quite a long time, Personalised care in the NHS was recently put into the NHS long-term plan, which came out in 2019, trying to make sure that everyone has a good experience of care that makes sense to them as a unique individual. And it's about looking at the individual as a whole person, going from a place of what matters to you, what's the matter with you, to what matters to you. So rather than saying, oh, what's wrong, what's the matter, what can we do, say, actually, what matters to you, what can I do to help you live the best life possible. It's about seeing people with skills and assets, because we all have them, as well as people in need of support or care, but making sure that people have the agency to dictate and to choose and to make their own decisions as far as is possible, and to support them in that, and putting the individual absolutely at the centre of their care, the centre of the services, and making sure that their wishes and preferences are upheld. But we must ensure it is truly personalised. I see it a lot where we have kind of tokenism, and we give people a little bit of control, a little bit of personalisation, but then we default back to, this is what the system has to offer, this is what things look like, this is how we work. And it's like, actually, no, this is a fundamental change to everything we do, where the end user, in business, the end user, the user experience is so important. Well, this needs to be absolutely front and centre in care as well, and social services. Fundamentally, at the heart of personalised care and of personal health budgets is this shift in relationships. Being seen as a patient with only symptoms and separate conditions that need treating? No. It shifts to being seen as a whole person with skills and strengths and attributes as well as needs to be met. People are powerless in the health and care system. Actually, no, they're not. This shifts to working in partnerships with health and care professionals, sharing that power, being on an equal playing field, and giving people equal say, equal right, and equal power in that relationship. And it's being asked, what's the matter with you? No, changes to what matters to you. It shifts that whole balance of power, and looking at a person, again, as a multidimensional person with lots of different attributes of themselves. And these images can be found with the NHS England Personalised Care Group and Lived Experience team, if anyone would like to look them up. There's a fantastic whole range of them that really do capture the essence of that change and that shift in relationships. So I wanted to talk a bit about personal health budgets, because I'm very fortunate to be born in the age where being on continuing healthcare means I can still have that user-directed control, that self-directed support, as we can in social care. And I actually started off my life as a teenager with a social care direct payments package. I was able to employ carers that met my needs very well. I initially employed a carer that was of a similar age to me. At 14, 15, I'd become isolated. I wasn't going to school. I'd lost all my friends. So social care direct payments gave my mum and I the chance to employ the people that met my needs best, again, similar in age, had interests. And those carers became my surrogate friends as well as my carers, and really supported me through those years. But the problem was my needs were medical based, nursing based, rather than social care remits. And we all know there's a limit to how much social care can provide. If the health needs are more than ancillary to meeting the other needs, then it falls under the health, the NHS continuing healthcare remit. But at the time, in 2011, you couldn't have a personal health budget with a continuing healthcare package. And so we ended up dumbing down my needs a little bit to stay just under the threshold for social care, just so we could retain that control. For someone who'd lost all control in her life, had many things dictated to her, that control over who was with me and what they did and how we spent our time was so important. Fortunately, a couple of years later, personal health budgets came in. I became one of the first people in Essex to receive one. And that was fantastic. And I'll tell you a bit about my journey of personal health budgets since. But personal health budgets is a different approach to commissioning, providing and managing care and support. And it puts the individual or their representative in the driving seat. So it's your wishes, your needs, your choices. It builds the care and support around the individual or their representative or as a team. It gives them greater choice and control and flexibility over how the funding is spent and how the care is provided, obviously within their personalised care and support plan. And it allows people to make their care work for them. Rather than fitting their care needs and wishes into the system, you're fitting the system into their wishes and needs, giving them that control. And the person with a personal health budget, or equally their representative, should be central to developing their personalised care and support plan and agree who is involved in that process. So perhaps they've got a hospice nurse, or there's a family friend that might want to be involved, or you've got other professionals, or there's people in your life, or even care staff that you have, thinking about who should be involved in that conversation, who is most important to the individual, not to the system, to the individual. Who should be there with that individual? It's being able to agree the health and wellbeing outcomes that they want to achieve, together with the relevant professionals. So thinking about what do they want to achieve with their lives, their care, their packages, what can we do together to work towards that? They get an upfront indication of how much money they have available to meet their healthcare and support needs. So this is crucial because it often gets missed. It's knowing in advance, this is the pot of money that the resource allocation system has allocated to you. Obviously, the personalised care and support plan might be slightly over, slightly under, but the fact is that's the kind of ballpark figure of what money is available to meet those needs as assessed by the resource allocation system. It's about having enough money in the budget to meet the health and wellbeing needs and outcomes. And the asterisk is there because actually if it's a young person, their educational health and care plan also plays into this, and their education outcomes also play in. And that is agreed in the personalised care and support plan. It's about having the option to manage the money in different ways. So that can be a direct payment, I'll come on to this in a minute, a notional budget, a third-party budget, or a mixture to meet the different needs. And I actually use a mixture myself. And it's being able to use the money to meet the outcomes in a way and at times that makes sense to the individual as agreed in their plan. So this is, again, the system working to the individual, not the individual fitting into the system. So the ways of managing a personal health budget, as I just mentioned, so personal health budgets can take three main forms. So a notional budget, so no money changes hands. The local authority or the CCG will still manage that money. However, they know how much money is available and they can decide with the funding authority how to make decisions about what that care is spent on, perhaps the provider that is used, how that money is managed, and thinking about, again, that shift in relationships. Although they don't take the money and manage it themselves, they actually have control of how it's spent, and that the choice and freedom and flexibility is still there. You can have a third-party budget, so an independent organisation can hold the funds on behalf of the individual and manage and administer those funds on their behalf. Again, shifting relationships. The user, the individual, is controlling how that money is spent, what providers are used, how they manage that package. But again, that third-party organisation takes the pressure off them and does the managing of those funds for them and holds them on their behalf. Or you can have a direct payment for healthcare. So a person receives the money to purchase the agreed care and support in our plans. And obviously we have to keep stringent records. It's not an easy job, but it's a fantastic way to give people that control. And I'm a big person on autonomy. And I think if you can give people that little bit of autonomy in their care, you give them greater autonomy in their life overall. So my own personal health budget is quite a complex package. So I mentioned that I've had a personal health budget for quite a long time, being one of the first in Essex. And in 2014, my personal health budget that I got originally, my mum was paid to do my nursing tasks, and then I had some hours with carers. So it was enough money for my mum to give up work and manage my nursing needs at home. But obviously I needed the nursing needs, so the carers could only care in between my mum doing my IVs. And that worked for us at the time. It meant, my mum and I could spend more time together. My needs could be met more effectively. My mum wasn't, working 24/7 and caring 24/7. And it was great. And we had the most fantastic time. Except in 2015, my mum sadly developed a brain tumour. And we had 3 weeks between her diagnosis and her surgery to build a very complex package of care. I needed nursing-based care because my needs can't be delegated, unfortunately. I needed 24/7 care, and none of these provisions were in my personal health budget because that's not what we needed at the time. And we later found out there was no contingency either. So off we went to the CCG and had lots of meetings, and the original feeling was that I was going to be put in a residential placement, and that, as they explained it to me, I would be unable to visit my mum, I would be unable to see Molly Dog, who's a big part of my life, I'd be unable to do my work, run my business, I'd be unable to do the things that really mattered to me, and I'd be stuck in a home, in a bed, until my mum recovered, or, as we later found out, had complications. It could have been for the rest of my life. But fortunately, we had a friend of a friend who's an advocate that stepped in and helped us fight for a new package. So I had a directly commissioned package to meet my needs, and that was provided by an agency. And the agency were okay. The staff were doing their best, but it just wasn't what I wanted. I wasn't in control. People really didn't care what I had to say. And I really found that hard. Having had all my life up to that point, having had agency and control over my care, to suddenly lose control at a time when I felt so out of control because my mum was ill, the one person that had always been there suddenly wasn't there anymore. That was very difficult. And as soon as, the package was put in place, my mum went off for her surgery and sadly suffered complications. She had a brain hemorrhage and a stroke. and really wasn't expected to survive at all. And when she made it through the first couple of days, we were expecting her not to be the same person, probably to need to live in a residential setting with very high care needs. But my mum, being the type of person she was, she did recover, and she's made an amazing recovery. But we realised at that point, those first few days after mum's operation, that this 24/7 package was not going to be for 6 weeks, like they said, just to get mum over the hurdle. This was going to be the long term. So about 2 months later, I said to them, and it's the famous thing, so when can I have a personal health budget again? That was all that I was focused on. I just wanted that control back. And then over the last couple of years, we've been building the personal health budget, and I'm now on the personal health budget, and I manage 24-hour care myself via a direct payment, but I have a payroll company. So I have 16 hours a day with a registered nurse. So they do my intravenous medications, my intravenous fluids, my intravenous feeding, my stoma care, various other complex care needs that need to be met by a registered nurse. I then have 8 hours overnight with a personal assistant. So they, manage my needs overnight when perhaps there isn't so much medical care going on. And then I have 6 hours of double up care, so 2-to-1 care with a PA alongside the nurse during the day. So that's for double-handed tasks like hoisting, washing, dressing. It's not always easy, but we make it work. And I enjoy having that control, being able to choose the people and have that choice over how my life is run. And as I said, I manage this via a direct payment. So I employ and manage the staff myself. That's including employing the registered nurses myself, which my CCG were a bit stunned that I wanted to do. But again, I thought, well, I've got the knowledge, I've got the skills, and I know how to gain the information I need. I want to manage those nurses like I do my PAs. So I manage that myself, and I have the payroll company manage the payroll for me. So I am the legal employer. The buck stops with me. I have to make all the decisions and do things by the book. But again, it's a price to pay for having that choice and control and being able to work with my staff in a level playing field. Again, that shift in relationships, rather than me being a recipient of the service, I manage the service myself, and it's a partnership between me and my staff. And I make the decisions around how my budget is spent. So although the payroll company manage the payroll, it's my decisions that decide how that funding is spent, what it's spent on. I send the timesheets in. I do all those different things. So it's about me being in the control and spending it in line with my support plan. If perhaps I want to spend something that's not in my support plan, going back to the CCG and saying, I've got this amount of surplus in my budget, could I spend it on this? And then getting their agreement. So even if it's not in the care and support plan, you can still obviously talk to the CCG, talk to the local authority, say, actually, could I spend it on this? I've got a bit of money left over. So my personal health budget support plan, it's built around what matters to you, what matters to me. And that's very integral. The first 3 pages of my support plan purely say what matters to me, gives people a real picture of who I am. And there's various different types of personalised care and support planning or person-centred planning. We all know there are many different types, the path and the maps and all those kind of things. And I think it's choosing the one that makes sense to the individual most. So for me, using a more of a path tool where you kind of go from where I've been. So my history is very important to understanding me today. So that is very much part of my plan, and centering it around, what I want to achieve, what matters to me. And it gives a clear understanding of what my goals are and what my life means to me and what I want to achieve with my budget. And it summarises my needs, obviously very important. It includes all the kind of medical side of it, how my needs are met and who by. So likewise, what tasks can be done by a nurse versus what tasks can be done by a carer. And also the important information about me, my life, my care. And it gives a 24-hour by hour breakdown of my needs and the care given to give the CCG and anyone working with me an idea of kind of my routine. And obviously that varies, but kind of there's kind of a pattern with my needs that's a bit flexible, but we can kind of work it out based on a 24-hour breakdown. So how the package will be managed. So how do I want to manage it? For me, I want a direct payment. I want to manage my staff myself. I want to employ my own nurses. I don't want to have an agency. I want to employ them myself. How I manage my staff. So what things I need put in place, what hourly rate will be, the shifts that I want people to work, all the things that will be integral to carrying that package out. Crucially, identifies the risks and how I'm going to mitigate them. So the power is with me. How can I make sure if none of my regular staff can cover my shifts, have I got a backup for that? So for me, if my regular staff can't cover my shifts, I go to my bank staff. If my bank staff can't cover the shifts, I go to my contingency agency. If they can't help, then my mum is my backup. So there's a process to follow and how I can mitigate those risks, and a whole procedure about how I can make sure I'm safe and well, and that no matter what happens, I can manage. Obviously, the important thing lays out the training needed for staff and core competency. So what do my nurses and carers need to know to be safe to look after me? the financial costs and the aspects of my package, including training, DBSs, all the relevant employment costs, plus the actual care costs. And it includes a solid contingency plan. My personal health budget, the original one, fell apart because of a lack of contingency plan. But would a contingency plan have perhaps been set up in the way that my mum was going to be completely unable to care? I don't know, but it's important we all have those contingency plans. We think about what could happen. We never thought my mum would become ill. The CCG never thought my mum would become ill, but the fact is she did. And we should have thought about that beforehand. And also for me, I have my personal health budget with my support plan, but I also have a separate notional budget with the CCG, which they hold. And that contains the contingency for my nurses with an agency. And I also have 7 days respite funding a year, which they, again, keep in a pot of money with the CCG, and I can access that if I need to. And I actually made that choice myself. I said, actually, I'd rather you have the contingency for the nurses and for the respite and keep that with you, just so that they could monitor if I was perhaps struggling and using a lot of my contingency. They might pick up on that if I'm too frightened to say that things aren't working. It was just a real decision for both of us. I think actually that was probably what works better for us both. So how do I manage the training of my staff and the clinical governance? Obviously, it depends what tasks the carers are doing. If they're doing delegated healthcare tasks, or like me, having nurses doing tasks, clinical governance is absolutely important for a personal health budget. We need to think about how we're going to manage the clinical needs, the decision making, the escalation of care. So what I do is I employ a senior nurse on my personal health budget, and she acts as the clinical governance manager. She has oversight of my package. She delivers some of the training to my staff, but also is responsible for checking their competencies. That's for both carers and nurses. So I've got that one person that I employ on a higher rate that just kind of takes a senior oversight role. And obviously, if I bring her in to do some training, she gets paid at a higher rate. If I bring her in to do some clinical governance management, I pay her at a higher rate. So that's built into my package. I have a detailed care plan. So really important, I've got my support plan that stays with the CCG and obviously a copy with me, but actually the care plan for my staff to use day to day. And that's very comprehensive. It's got all the information they need, a list of important contacts, all my medical needs, the various companies that are involved in my life, you know, the hoist people and the TPN company and all these people that are integral to my team, that if I wasn't perhaps well or needed someone to take over, that they've got all that information that they need. But they also know all the care protocols, all the you know, the procedures we've got to do, all the information they need to manage my needs. So for me, when new staff start, we try new shadow shifts to give them a chance to see things in practice, but with another nurse or another carer present, to get that kind of feel and to just ease them in. Because, you know, for a lot of nurses, working one-to-one in the community is quite difficult. They don't always know what to expect. They find the element of being on their own very hard. So I have to overcome that by supporting them to say, actually, it's not as scary as you think. Yes, I look terrifying on paper, but the job is not that scary. And my training for my staff includes 3 hours per nurse per year for training competencies in my central line, my intravenous medications, my TPN. We've got online mandatory training for all staff, stoma care training from the local hospital. And then I've got a specialist package of training that myself and a hospice, Francis Hospice, built together for my staff. So it looks at holistic, person-centred and palliative care. Because obviously my staff, whilst they're training to look after me now and live my life to the fullest, end-of-life care will inevitably be part of my package at some point. I'm 10 years beyond my prognosis and I'm determined to be for a long time yet, but at some point we're going to be in end-of-life care. So they need to be equipped, both physically and clinically, but also psychologically, for the fact that I'm so alive and doing so many things now, but at some point that might change. And we have staff get-togethers and social days. So perhaps if I get the staff together, perhaps at the hospice or at home, have an extra bit of CPD and training while they're here, have some social opportunities, because building that sense of team was really important to me. And I had quite an unusual request. So I requested aromatherapy massage training for my staff. Now, pain is a big part of my life, especially in my back. And we've kind of exhausted all medical treatments. And unless I go on ever escalating higher doses of opioids, I'm already on opioids, but unless we keep escalating the dose, in which case I will become more and more sedate, there's nothing much we can do. We've tried all the NHS offerings, we've tried complementary therapy, but the one thing I find that helpful is aromatherapy massage. And the thing was, they could give me, I don't know, £100 a week to spend on sessions, to bring in an aromatherapy massage practitioner to come and give me a massage. And I said, but actually, for £80, you could teach my staff how to do it. And then I could have 10 a day if I wanted, or any day of the week, any time when it suited me, to help with my pain relief. When my pain is flaring up, when I need a bit more support, my staff are equipped in those skills to help manage my pain. And because of that, I need less turning, I need less support, and I'm more comfortable overall. So it was a bit of an unusual request, but again, I evidenced the need and the outcome and how that would benefit me. And my CCG Julie said, yes, that is meeting a need. You need less medication, you need less support. That's fantastic. So why is my personal health budget so important to me? So for me, you might have heard these words a lot. So choice, control, freedom, flexibility. Those are the words I often use to describe PHBs, because it is about the choice over how you manage your care and who looks after you, the control over how that money and that care is managed and who you have and when they work, the freedom to actually say, this is my personalised care and support plan, these are my outcomes, how can I meet my needs with that budget, perhaps be a bit flexible to meet those needs, about those flexibilities. It's the making my needs and the package work for me and my life to enable me to do the things that I want to do. And again, giving greater autonomy. I mentioned that earlier. If you can give someone the control over their budget, even if they have a notional budget, but they know what that budget is, how much they can spend it, they've chosen the provider, they've chosen the hours they're going to work, they've chosen what they're going to do, that gives greater autonomy. And I think in the advocacy world, we always want to give people their autonomy back. We want to show people they've got a voice and they can use it, no matter what their ability and no matter how they communicate. There's always a way that people can be more autonomous. They might not have capacity to make all decisions, but they have capacity to make some decisions for them, or when they're happy with the decision that's been made. So I get to choose the people I have around me every day, which are my staff. They're in our home 24/7, so it's quite hard for my mum and I to have people here all the time. So choosing the right people is absolutely important. And I can also select candidates that work well with us, so they kind of slot into our family. And I often describe to my staff, you need to be there when we need you, but be invisible when we don't need you. So we don't feel like we've got a stranger in our home all the time. We feel like we've got another family member there who's kind of in the background if we need them. They're there to do my needs, they're there to do this. But if me and my mum want to go and watch telly for a couple of hours, they come in, they check on me every 20 minutes, half hour, but they're really not there. We don't feel like they're there. So that invisibility is quite important. And I can make the package work for me with a personal health budget. I can use that funding in line with my support plan to meet my needs. I get to decide which staff member works when, what we do, what shifts they work, what we do while they're on shift. It gives me the ability to do my paid employment and my paid work, which is a big part of my life. I worked very hard to be off benefits and in paid work, so that's a big part of my life. I'm able to run my business, but I'm also able to do my voluntary and advocacy and committee work. And the thing is, it's me and my team. Not an agency telling me who's going to come and sending a stream of people that I don't know and I don't choose. It's me and my team. I get to choose them. We work together. We're on a level playing field. We share that power and we work together, but I am the employer at the end of the day. So how does advocacy fit into this picture? So advocates have supported me in my life and made such a tremendous impact. I spoke at the National Advocacy Conference in 2016 and shared some of this journey. So if anyone's heard it before, but it's a real positive impact on my life. So yes, I'm bright and articulate and educated, but I still benefited from advocacy support myself. And the person that sits before you today, very confident and very capable at interacting with the system and professionals, wasn't the same person when I was 14. I was very shy. I was new to the system in many elements because we'd always managed on our own. It was a real difficult thing to grasp, that I had to speak up for myself. And I'd go into a medical appointment, for example, and when they would say, "How are you, Lucy?" And my mum would just start talking because I wouldn't say anything. I had to learn those skills of advocacy. People aren't born with self-advocacy skills. You have to teach them. And originally, when I was a teenager, I had a children's advocate. And this advocate was the first person in my life at that point that showed me that I had a voice. I was so used to being dictated to, told, having things taken away from me and having decisions made on my behalf, that I didn't actually realise that I had a choice and I had control and I could use my voice to affect change. And I was so lacking in confidence and so in awe of the system. I felt so disempowered that I didn't know I could actually speak up. And that actually it wasn't just that I could speak up, but I had to speak up. If I wasn't going to fight for myself, no one was going to fight for me. There wouldn't always be an advocate present, as you'll say in a minute, but it was about being able to see that I had a voice and that I could use it. And this advocate really did challenge my staff and the people involved in my care. She really made sure people knew Lucy. She spent time getting to know me. We talked about endless things, but also she had a daughter that was a couple of years older than me who was disabled. And she'd bring these stories to me of what her daughter was up to, what she'd been up to at college and where she'd been off. And at one point she went off traveling around America with her PAs, and hearing these stories of a disabled person, a couple of years older than me, living a life. I'd lost my life. I'd lost all hope for a future. I wasn't expected to reach adulthood, so I wasn't expecting to have a future. But again, this advocate really told me these stories and helped me to see that I had a future and that I could make an amazing life for myself. Yes, I was going to die young at some point. Probably we would have thought before now, but I'm still here. But it was really important to have that kind of hope for the future. And my advocate gave me that. Unfortunately, as things do, the criteria and the commissioning arrangement changed. So I lost this advocate. And then unfortunately, I transitioned into adult services.
You okay? You're on mute, Lucy.
Sorry, what can you do it a bit funny then?
All right, maybe the internet dropped.
Yeah, I don't know. But
people are loving it.
Great. So the service changed, and obviously the criteria changed for that service, and I lost my advocate, and that was such a big loss for me, because that was that one person that understood Lucy, fought for Lucy, showed Lucy that she had a voice, and suddenly she wasn't part of my life anymore. But we managed, as you do, you just manage. And then about 4 years later, when my mum became ill, we needed that support again. I needed someone to help fight for me, because my mum wasn't going to be there to be that second person. So we luckily had a friend of a friend who was an advocate. And she supported me, she helped fight, and she helped chase, and again, really was there for Lucy. And the thing is, obviously, the Lucy 5 years ago now was more equipped than the Lucy as a teenager, but I still needed that little bit of support. And my advocate, the friend of a friend, she was very good at, she let me say everything I needed to say, but if there was something she needed to pick up on, she was there. And she was also that one presence in there. Some meetings she said nothing, but she was there for me, and she understood me. She took the time to get to know me. So no matter who came into that meeting, I was obviously having someone that knew me and understood me and actually was there for my voice and my voice alone. And again, as I said, I am knowledgeable and articulate. I'm able to speak for myself, but even I could benefit from advocacy. And even now, that advocate that supported me 5 years ago, I still keep in touch with her. I ask her advice around things. She's that one person that's been there through that journey. And also in all the riffraff with my mum being ill, she was the one person that really checked in with me. The services often didn't have time to spend an hour a week just talking about how I felt, but that advocate was there. She was kind of my conduit to release that emotion and just talk about the things that upset me more than anything. And she really was, I don't think I could have got through it without her. And I think when you are an advocate, I don't think you always realise the impact that you make. You really do change lives. My life has been changed. I'm able to be the person I am today because of the advocates I've had. I've got the life I have because of the advocates I've had. And I think, I've not only learned skills from my advocate and been supported to gain the skill of self-advocacy, but I've had people that have been there to back me up, to validate that what I'm saying is right, to validate that actually that's wrong, we need to change that. And that was so important to me. And I still hate challenging things. I still hate making a fuss. But my advocates are kind of in my back of my head saying, Lucy, you need to say it. You can do it. And that little voice at the back of my head thinks, actually, I've got the confidence to do this. I've got the skills to do this. And I am right in challenging that. So now what do I do? So over the years, obviously, as I grew in confidence, started doing the work I do, I started to become, peer advocate for my peers and do peer brokerage for people. And I quite enjoyed it, actually. I found that I was quite good at it. And having been through the system, been through all these things, I understood implicitly what it's like to be on the receiving end, to not have any power, to not have your voice heard, to not have control over how your life is lived and what support you receive. And before I knew it, this caseload was growing. I was getting people referred to me from all over the country, really to have help for people with very complex medical needs more than anything, or parents of children with very complex needs. So with Kate and Black Belt Advocacy, I did my level 2 award in independent advocacy to support this. And now I have my business. So I work as an independent advocate. I have a specialist knowledge in kind of NHS continuing healthcare, personal health budgets, integrated funding. So I did have an integrated budget at one point, NHS advocacy, and also Care Act. So those are the kind of places I have the most experience. And I really stick to that niche because I often find a lot of people don't necessarily understand NHS continuing healthcare. I've lived it. I know the framework inside and out, and I can support those people because it is a complex process and it does feel very disempowering. It's making sure people feel that they're doing the right thing, that fighting for themselves or their loved one is the right thing to do and not to be put off. I also began to work as an independent support broker. So again, personal my health budgets are my particular expertise. So I've got a CCG in the north of England that commission me on a regular basis to do some of their brokerage for their clients. I work on cases across England, so that's with various commissioning arrangements. So perhaps one CCG will commission me for an individual, another will add that into their budget support plan, so I'll be paid when the budget is signed off. All these different ways of managing that funding, but enables me to be being paid work, but also to help other people in a way that benefits both of us in a way. And recently, building a care package for an individual privately, I was contacted by someone to build a package, and we're doing that because they self-fund. So using different resources to commission my work, but making sure obviously I can survive and I can give the best service to my clients. And also that CCGs are open to, not just using the services they've always used, but using people that are good at what they do. And I remember one of these CCGs said, when I finished one of the clients, she said, "But you're a good broker. She says, you understand personal health budgets more than a lot of the other brokers do that work across the spectrum. So that's why they keep commissioning me." And that's kind of my life with a personal health budget. And I want to talk a bit about lived experience. So my lived experience has enabled me to be where I am today. If I'd have been healthy all my life, I knew I wanted to be a doctor. That was the life I had pictured for myself. I was going to be a doctor. I was going to help people. And my illness, the older I got through my childhood, the more those choices were being taken away. That dream of being a doctor was fading away. So it was very hard. And I floundered for a long time. Then you're being told that I wasn't going to live to my 18th birthday. And it was so hard. But then I managed to gain back kind of a sense of identity and a sense of confidence and a sense of purpose. And my lived experience is what enables me to do my job effectively. Not only do I know the system and the policies and the frameworks that we work in, but I've lived the system. I know what it's like. I know what it's like when someone forgets to call you and the stress that causes. I know what it's like when someone makes a comment that seems really harsh. And I can say to someone, actually, it's not that's not quite how they meant it, but that's just the wording used in a policy or a framework. Thinking about what can I do with my lived experience to benefit other people. And my lived experience isn't necessarily the only part of me, because it's not, but it's something that enhances my work. It informs who I am and it informs what I do. And also what I'm good at. I've been good at a lot of things because I've been ill, and I'm not defined by my illness, but I live with, despite, and because of it. It's all three. And I can help people to understand what it's like to be on the end user, so the recipient, the service user, the patient, what it's like to face those big obstacles, to be in part of the system, to feel so disempowered, to help people understand the difficulties faced by us, and actually how also staff, likewise, professionals that work in the system, I can also advocate for them, because I've seen and worked with so many professionals. I know the impact it has on them and the difficulties they face. And the thing is, we all have lived experience. I know we often think of people with lived experience as having a disability or a health challenge or a learning need or something like that. Actually, we all have lived experience, and that informs everything we do, our thoughts, our values, our perspectives, our behaviours. And how do you see your lived experience? Do you see it as an asset or as a hindrance, as a help? For me, the lived experience is never invalid. So there is no lived experience that doesn't help or impact upon you in some way. So it might not always be a positive thing, but we all have lived experience that all informs who we are and how we interact with the world and the decisions we make. And it's always valuable. There's always something to be learned from your lived experience. You might, I don't know, have an interest in, I don't know, let's say cars, and you've worked in the NHS for years, but then you come across a young person with a learning disability who really likes cars. Your lived experience is helping that patient because you can be on their level with a topic that makes sense to them. So never dismiss your own lived experience, and really think about how you can use your lived experience for the best impact. We've all got it. Now let's use that lived experience to impact the system and impact the lives of other people. And as so aptly put by Warner Slack, a visionary physician, he said that patients are the largest and least utilised resource in healthcare. And I think that's absolutely right, because we don't use patients, and we are here, we understand the system. And I've always kind of said, if you put nurses and patients in charge of the NHS, I reckon we could run it a lot better. I bet if you put advocates in charge of a lot of the services, I bet you'd make such a difference. And it's about that lived experience, but also combining that with professional experience. So just before I finish, just wanted to say that for advocates for me, both as in my life personally and the impact I've seen on other people, you do change lives. And I use the phrase when I gave my speech in 2016, you are our heroes. You are the one person that comes to get to know us, learns about us, supports us, validates our experience, and is there to fight for what we want and need. So never underestimate your power, but make sure you share that power and empower your clients as well to see that they've got a voice and they can use it, and support them to be whatever they can be, whatever they want to be, whatever matters to them, and put them at the centre, as you so well do. But it's about trying to teach these people the skills so that one day they can speak for themselves, even if you're still in the background, that they know that there's someone there that always there for them and that will always support their voice. So I'll obviously open the floor for questions now. I'll stop sharing my screen and then we can see you all, or you can see me.
Whoop, whoop. Wow. So much love for you, Lucy, in the chat box. I'll send it to you later. I think you'll be, if your goal today was to make a difference, consider that achieved. Amazing. Thank you so much for those insights. And I think one of the things I love about Lucy the most is that she's an advocate, not just for herself, but for others, aren't you, Lucy? So, right, okay. Michael's just said you're a powerhouse.
Thank you. I do my best.
We do our best. Yes, all we can do, isn't it? Right, I've got some questions, so brilliant. I'll put these to you, and then please, other people do pop questions. It's going to be difficult for me to manage the chat box now, so if you can put questions in the Q&A box, then that'll be easier. Okay, so first question is about notional budgets, and advocates finding problems with notional budgets where some agencies might be more expensive, but the CHC has identified a set number of hours, and that kind of tension between set number of hours versus the budget. Any insights or thoughts on how to address that?
So to address that, I think it would be a conversation with the CCG that are funding it and the local authority if it's a joint package, and talking about why that provider is necessary to meet the needs of the individual. So it comes down to needs and rights at the end of the day. Yes, we could probably find an agency that's really cheap and that can do it for that amount, but actually this is a person with an individual need, and the agency we've selected has got particular expertise in that need, or is best placed to meet them, or is more committed to giving a personalised approach. That is the whole point of personal health budgets. And if we're not giving people the choice to choose a provider that meets their needs best, then there's something wrong with what we're doing. So it's about challenging that decision and working with the CCG to see the benefit. And it shouldn't be actually be about hours. I know we commission them based on hours, but it's about using that budget to best meet the needs. And if you can evidence, like I did with the CCG, I went back about a pay rate, I did evidence for that, and I went back about, the aromatherapy massage. It's having that conversation and giving that evidence as to why this is the right agency and why that cost meets the needs. And again, if you can get that research together, get that information together and give that evidence, that is the best way you can achieve it. And not all CCG is open, but actually if you can evidence that need and why that's important, you can start that conversation. And if there's still something wrong, then you can take it further up the chain, really, to say, actually, this is what the person needs, this is their needs, this is the best agency to meet those needs. For someone like myself, yes, you can get an agency that's got any number of nurses, but they're not going to be specialist in my need. So I needed to have an agency that met and that wasn't the cheapest. Mm-hmm. But my CCG saw the benefit that actually I would end up getting the wrong care, or the wrong type of care from the wrong people if they'd commissioned the agency they'd originally thought of. So they went for the higher agency because, again, we could get evidence that met my needs best. Yeah.
Thank you. Listening to you, it makes me appreciate the importance of advocates kind of influencing the direction of the conversation. So you said at the very beginning around, the question shouldn't be what's wrong with me. The question should be what's important to me. And I think advocates just pushing for that being the conversation then makes a difference, doesn't it? So as you say, instead of it being about money, it should be about quality and about, which is the most effective. And I know it might sound easy, in a room just saying this, but I think that can really make a difference, can't it?
It is, and it's being willing to challenge the system, actually, because it might be a nurse assessor that comes to see you, but it's not her that will make the funding decision. Actually, it's the fund. And again, if you can build that evidence pile, like for myself, she took that evidence pile that I'd put together as to why I needed the rate I needed, took it back to the funders, and they agreed it because they could see the rationale. Yeah. But often that rationale doesn't get from the nurse to the funders, so it's making sure that rationale gets into that funding meeting.
That's great advice for advocates to be thinking about that. That's great. Thanks. Right, second question. Any views on what people might need if they aren't as articulate as you? And I appreciate you said that you haven't always been this articulate, but so kind of perhaps drawing on that experience and that journey, what kind of tips or views have you got? And I think that the concerns were about if people perhaps aren't as articulate, that we might have this like two-tier system where people aren't getting access to PHBs because of a learning disability or because of non-verbal communication or things like that. So yeah, any views?
For me, I think, again, it's empowering the person and their family. I think that's not only do I didn't say this, but not only do my advocates empower me as a person, they showed my mum how to fight as well. So even if there wasn't an advocate present, my mum was learning the skills of advocacy, because I wasn't disabled from birth. So we, although I had my condition from birth, we didn't realise I was quite as ill as I was for the most part of my childhood. So she didn't have those self-advocacy skills. I didn't have those self-advocacy skills. But those advocates empowering us gave us that little bit of wherewithal, that information, that knowledge, and that confidence to actually say, this is wrong, this is what I need. And I think a lot of what advocates really need to do is teach, but also role model.
Yeah.
So you're in that meeting, you show people that you can actually say this is wrong because, and people will change it. You can actually say, I'm not happy with this service, please can we discuss it? Teaching people those skills so that even if they're not always there, that they can make their decision. And that might not be just for health or social care or PHBs, that can be across the spectrum of system. Going to get a wheelchair and perhaps someone doesn't understand the person's needs, using that advocacy skill. It's teaching people. I think it's about giving people the knowledge and translating that into a way that makes sense. We all know policy language is the worst thing to try and decipher if you're not initiated. How can you explain that to the individual and their family to say that actually this is important? So it is about working with the individual and their family. My mum is still part of my care. She doesn't have to be, and I did it all on my own while she was ill, but actually I want my mum there. So she's still that backup person. So it's about teaching the whole family, translating that language, giving them the information, and just giving them the power to say, this is not right, this is what I need, and this is what I want to achieve. Because that's really important, that self-determination, that confidence and that autonomy. It's really hard to know, obviously, in each individual situation, how it's going to pan out. But I think if you can teach the individual that skill, and that young person that's, I was transitioning into adult services, suddenly I was the only decision maker. So I had to learn. And the advocate was the only person that prepared me for that.
Yeah. Love it. Absolutely love it. And I think you're right. It's something that we don't appreciate that you're doing, but you are role modeling every meeting when you politely, respectfully say, hang on, we need to question this. People are watching you do that. People are learning how to do that. Yeah. Great point. Any insights into how to access home adaptations for people whose needs change dramatically?
So again, obviously, disabled facilities grants, we all know the process is incredibly slow. But there might be money in a budget that actually could be used in some way. I'm not necessarily saying it could adapt the house, but there might be equipment that could benefit that person's needs. And if they've got that money in their budget, you could go back to it's not in their support plan, but you go back to the CCG or the local authority and you say, we've got this much money surplus in the budget. There's this piece of equipment. This is why it will meet the needs. This is how it will help people, and kind of support people to access that equipment. And if you've got that agreement from the CCG and you can give them that rationale again, giving that, so when that goes to the funding meeting, the funding people absolutely understand the rationale behind that piece of equipment. It's making sure that you use the budget. The budget is there to be used flexibly. So let's think about, it's not always hours, it's not always care, it's not always what we always think of as care. It might be an iPad for someone that struggles, gets fatigued and doesn't always be able to communicate. It might be a shower chair because the one they've got, they've outgrown or isn't specialist enough. It might be that they need an adaptation to their wheelchair, so they could have part of their budget could go into personal wheelchair budget. There's thinking about the budget in terms of outcomes. What could best meet the outcomes of the individual with that pot of money? And if you've got some hours surplus, or you could save up some hours, perhaps they didn't need 2 hours a week, well, you save that money up and you say to the CCG, this is what we're aiming towards, this is what is going to meet the person's needs. And that's how we think. So we need to stop thinking about budget as care. It's about needs and outcomes. So think about outcomes first and then evidence that.
Work backwards. Oh, I love it. And again, it's keeping control of that narrative, isn't it? Gorgeous. Yeah, great point. Okay. Question around your own personal health budget and the plan. How hard was it to implement it initially, and any kind of tips that you can give advocates and people on the call today with this?
So I think for me, the hard thing was getting it signed off. It was dealing with all the potential issues and thinking about that, and then but actually, because my support plan was so detailed and so comprehensive, and I'd taken it, obviously because of the work I do, I work with a lot of professionals, so I'd actually taken it to lots of different professionals for their opinion. So was there anything I was missing? Obviously, because I employ nurses, I've not employed nurses before. I was going to the NMC and asking advice. I think that was that was so important to that process, was preparing myself as I was writing the plan, preparing myself for implementing that. So I think you need to stop thinking about plan first, then implementation. You need to think about implementation throughout the plan, so that when it comes to that sign off, you're kind of prepared for that. Implementing it is not always easy. It's a bit fragmented at first, and you're finding your feet. You might have new staff joining, and then, like for myself, you know, we trained a couple of staff and then they just found it wasn't for them, or the traveling was too much because they were too far. And it's just trying to think about the implementation from the get-go, and also having those contingency plans. So for me, my mum can act as a contingency, and obviously in COVID she's had to, because the normal parameters aren't there. But actually thinking about, how can I meet the needs in whatever circumstance? Being in touch with that contingency agency, being in touch with the CCG. You know, if there's an issue, go straight to the CHC nurse and talk to them, go straight to the social worker and talk to them. But it's about that kind of preparing in advance and preparing for a bit of flexibility. I know that sounds awful, and things aren't going to go perfect first time, but if you've thought of the problems in advance, you can kind of mitigate those before you get there.
Lovely, thank you. We've had a request for you to talk to a self-advocacy group. So are you happy if I hook you up?
Yes, of course.
Yes. Okay, Rosie, expect I'll make a note there to hook you two up. Have you ever used the Ombudsman to achieve, and that could be for yourself or for one of your advocacy partners?
So I haven't actually gone through the Ombudsman process, but I have referred people that way. And I think there's a case I'm working at the moment that, again, we've had to challenge quite a lot. And the next step, if we don't get anywhere, would be the Ombudsman. So again, and likewise, you know, because I haven't done it myself, talking to people that have used the Ombudsman, using the resources online, reading some of their reports, really being one step ahead myself as an advocate. You know, I might not need to access that service, but make sure that if I do, I know what is there. And I think research is so important. If we can research, talk to people, and we all know as advocates, we learn through every case we do. So every case you're benefiting from. So, and I always like to give feedback back to clients, actually. You know, I've learned so much through working with you and thanking people when I work with them, because actually that's a bit of, you know, common courtesy, but it's also they're helping me as an advocate and I'm helping them. But I think I've always tried to stay one step ahead of my clients. So, for example, this particular case, we escalated higher up in NHS England. So that was the first step. Obviously, if that doesn't work, then it will go higher. But actually, I'm always trying to stay that one step ahead. So if we need to go to the Ombudsman, I now know how to access it, the kind of language and policy and terms. I've thought about, so I haven't written out the full like contact details and the piece for contacting them, but I've kind of given myself a note of all the key points I need to make, the timelines of the case. So I've gone back through my case notes, made a timeline of events since I've been involved, what's gone on beforehand, talked to the family. I've tried to gather that knowledge all the way along, so that if I need to escalate it, I've got it there and I can just go straight into it.
Great. Advocacy toolkit, isn't it? Yeah. Last question, I think, and then you can have a breathe. Is any tips or kind of views on people who are fearful of challenging the CHC? And the example this person's given, is that there's a fear that the person might be put into care, or I suppose that age-old concern that of repercussions or being punished for making complaints.
I think we all know that it shouldn't happen. We all want to think that the system doesn't behave in a certain way, but the fact is it does. But I always say to people, it comes back to rights. And also, just because you've complained, unless that CCG can prove that that person is so unsafe, they cannot be managed in a community setting, really, that their rights trump that, they would have to evidence that there was no other way of meeting the need in the community before you can kind of think about those situations. So it's, again, coming down to rights, again, changing that narrative from, you know, they're just complaining for no reason, to actually, this is a problem, this is what we need to do to solve it. They are an individual who has their rights and agency. They want to stay at home. We have found, like for me as an advocate, I often go and contact agencies for clients well before we were at that point, so that if anyone tried to say we can't manage their needs in the community, I can say, well, actually, there's this agency in this place and this agency in that place, and I know of staff, or I know of a package or a case law, or it's about combining all that knowledge and saying about it. But it's coming down to, this person is an individual. It's their choice to stay at home. There is no safety reasons. There's no safeguarding concerns that mean they cannot be managed in the community, and they have a right to choose that. And yes, I know the system is scary to kind of challenge when you think you're going to get repercussions, but I think there are effective ways of dealing with that. And if you don't deal with that, you're going to be worse off.
Yeah. Lovely. Lucy, thank you on behalf of the 130 people on the call. I think at one point we got up to 140 listeners. So as I said before, you're definitely having an impact, and yeah, I think we've all learned loads there, haven't we, and about the process, and I think people have been reminded how kick-ass advocates can be.
Yeah.
So thank you. Did you want to have any last words?
I just really want to say, thank you for all you do, even though if your client cannot thank you. I, as a client and as an advocate, can say thank you for what you do. You will never appreciate the difference you make. That one sentence, one word, one little gesture can actually transform someone's experience, and it's just having someone in their corner. So make sure that you give people the power, you give them the choice, and you show them that they can have a voice, and that voice can actually affect change in the system, whether it's them speaking for them or them speaking for themselves.
Boom.